Amanda Falk. I am a partner and chief clinical officer at The Dorm, which is a treatment community for young adults ages 18 to 30, give or take. As a multi-diagnostic treatment community, our clinicians often work with clients experiencing acute mental health concerns, including schizophrenia and treatment-resistant schizophrenia. This is why we are super excited to be here today with an expert on the subject, Dr. Rocco Marotta from Silver Hill Hospital, who will be speaking on this very subject. Dr. Marotta is a licensed psychologist and board certified in psychiatry and neurology. He is also an assistant clinical professor at Yale University. He graduated from Manhattan College, where he majored in psychology and Western civilization. After earning his PhD from the City University of New York in psychology and neuroscience, he completed a 3-year NIH fellowship in biological psychology and psychiatry and a 1-year internship in neuropsychology at the Montefiore Medical Center and Albert Einstein College of Medicine. Dr. Marotta went on to earn his medical degree from Cornell University Medical College and completed his residency in psychiatry at Weill Cornell Medicine Payne Whitney Clinic. So with that very impressive bio, and without further ado, I'm going to turn this presentation over to Dr. Rocco Marotta.
Thank you, Amanda. And thank you all for asking me to speak. You know, we've had a relationship between you guys and us at Silver Hill for years, but we hardly ever really see each other. And it's good to do this. I want to apologize for my mixed Bronx, Brooklyn accent and cadence, and I hope people can understand me and it's coming through clearly. So our service here at Silver Hill is a neuropsychiatric service. That means we see lots of young people with pretty severe disorders, and it's very much focused on the treatment of what would be psychosis. In my experience, now that I'm an old man, is that the way in which cases appear, how they present in our language, and the treatments have been changing over the last 20 years. Things are in some ways much more difficult. So I'm going to start with that as sort of the background. So schizophrenia is a disorder, it's a developmental disorder, it's a brain disease, and in many people, it's a chronic degenerative disease. What strikes most people is that there are psychotic symptoms. And so just to lay it out, those symptoms are hallucinations, delusions, disorganized thoughts, speech, abnormal motor behaviors, catatonia, and also negative withdrawal symptoms. So most of the cases of psychosis that present in a country like ours are diagnosed as schizophrenia or schizophrenic spectrum disorders. So just to put it in the modern language. And that schizophrenia is a chronic mental illness. Again, it has positive symptoms, it has negative symptoms, and it has cognitive impairment. So it's a pretty wide-ranging disorder. The positive symptoms, again, are delusions, hallucinations, disorganization. The negative symptoms are lack of motivation, lack of social connection. And the cognitive symptoms are noted in, when you measure them, in deficits in IQ, but also really deficits in educational attainment and life attainment. Now, most of the treatment of the last 50, 60 years has been centered on medication treatments, right? That there are medicines that can contain the overt psychotic symptoms, delusions, hallucinations. But the real bread and butter of it in saving people's, lives and families and society was not just getting rid of the overt symptoms, but doing something in the end about the withdrawn negative symptoms, and also to be able to, in some way, impact cognition. And that has not been such an easy thing to do, because in many schizophrenics, there is deterioration. I just want to say again, a name like calling a disease schizophrenia, you would think that it's talking about, we know what it really is, but we don't. There are many different diseases, maybe, in our language, pathophysiologies that lead to what we see. So there's no single illness, in my belief, schizophrenia. There's a spectrum of disorders, to use the old language of the great professors of the early 20th century. Does that work? So just to give you some of the names that are used for it, there is schizophrenia itself. Historically, up to 1% of the population of industrialized countries has this diagnosis. Schizoaffective disorder, which we now see much more of, is when you have emotional dysregulation, either depression along with the schizophrenia or bipolar disorder. And these are just numbers that are, from studies, but you can see that if you add a 0.7 and 0.3, you get to about 1% of the population. Schizophreniform disorders, again, there's a percentage less. Things that may look like schizophrenia may be the beginnings of it. Delusions without the decline in functioning, again, there's a percentage of the population who have a schizophrenic spectrum disorder, not a full-blown one. Grief disorders, look at those numbers. If you get 10 out of every 100,000 people, you're taking one out of every 10,000 people every year, especially in young people, who are presenting with brief episodes of psychosis. And then we get down to what's really happening around us right now, which is very large numbers of substance-induced psychotic states. The real kicker is whether or not they will evolve into full-blown schizophrenic spectrum disorders like schizoaffective and schizophrenia. It's my belief that that is actually what's happening. To give some more numbers, roughly 3% of the people in the US experience at least one psychotic episode in their lives. I have post-surgery twice. I don't know if it counts in these kinds of numbers, but drugs, anesthesia can do that, also steroids. 100,000 teenagers a year are estimated to have their first psychotic episode in this country every year. Also, 120,000 people are dying of drug overdoses a year right now. This is an incredible, terrible situation, right? The average age of psychosis in terms of being clocked into the system is 24. I think the average age of presentation is actually quite a bit younger, and as a consequence of the use of marijuana and drinking in the general population at this point. The other disorders, just to feed the horse a little bit, that can involve psychosis of bipolar illness, severe depressions, 14% of them, will evolve into depressive states. There are postpartum psychoses, and again, the substance abuse psychoses, which are more and more prevalent. And what is this doing to society? Well, you can look at it like a good capitalist, and say, what is it costing us? The burden to the country is said to have doubled just in the last 6 years. They're giving numbers like $343.2 billion in excess cost because of a schizophrenic illness. The average cost of a person with schizophrenia, excess cost per year, is something in 87,000 back in 19. So I suspect with inflation and other things, it's over $100,000 a year right now. They estimate indirect costs are over 70%. In other words, what does it cost a family to care for a schizophrenic child? What does it cost the people around them? And there's other things you can't really, they can't give them numbers in terms of real cost in terms of money, right? I mean, what does it do to someone's life? Schizophrenics have 10+ year decreased life expectancy and more illnesses. What does it do to their families? There's the financial and emotional burden of caring for sick people. And there's the fears of what it means to the family and the disruptions. It also disrupts communities, if you think about it, to have large numbers of people suffering from psychotic illnesses. When many of us were young, there were state hospitals that no longer exist. We now have many people being treated in communities and on the streets who had not been treated in that way previously, all right? So you've got about 1% of the population, almost 40% of those entering treatment, multiple treatments, failed treatment, all right? So you have a degenerative disorder, it's chronic, it disrupts people's lives, it disrupts communities, and this point of treatment resistance is that even with medications which are sold as antipsychotic medications and approved to treat schizophrenia, you still have a huge burden of people who don't respond in a way that is good for themselves or good for the people around them, for society as a whole, and for their families. This treatment resistance, again, I think is becoming much more prevalent, okay? I think the illness is taking on a kind of turn for the worst, and I'll try to talk about that just a little bit too. Now, in addition to saying that 40% are treatment resistant, even the people who are responding to medications are still not living up to what might be their full potential. I mean, almost once a month, I get a phone call from a family that has a child going to Harvard or Yale who are developing a psychotic disorder. And I followed some of those people over the years, to get into, elite schools. People have IQs of 130, 145. They rarely live up to the promise they had when they were in high school or early in college. So they may not come apart completely. They may not even be called totally treatment resistant, but something was sidetracked, something came undone. And so you see this as a degenerative illness, which really interferes with one's personal productiveness in many ways. It's a real burden on society. And well, why is there failure? I mean, Dr. Doherty and I were just writing some of these things down. There may be a lack of a social support, right? We don't have the mechanisms in place in society to support people so they can get better. Substance abuse in the 21st and late 20th century is very, very high and affects the brain, and it's a brain disease. Some people are in treatment, but they don't comply with their treatment, with their medications or other treatments. That leads to losses in cases. It also might be that our pharmacological agents or pharmaceuticals can't intervene properly in the illness, that we don't really understand the real pathophysiology, even though there are theories about what the pathophysiology is. It's a disorder of the dopamine system. It's a disorder of the frontal lobes. It's a disorder of the, of other specific neurotransmitters. And we make drugs to intervene, but they don't necessarily work because it's not a single disease. It's not due to one thing being wrong. It's a complex developmental disease in which subsystems, not only within the person, but between people, break down over time. There are also, in the last decades, enormous amount of increased social, cultural, environmental stresses, right? I mean, in the climate, COVID, increased violence, social disorganization, right? But from my standpoint, given how I think about things, we don't really understand completely the underlying neurobiology of psychosis or more specifically schizophrenia to know exactly how to proceed, okay? And now, I've been saying it. Is it really getting worse? Well, I'm a West Sider, right? I grew up on 95th Street. When I was younger on 119th Street, is the city different? The city over the last 30 years to me is quite a different place, right? Maybe it's my selection bias, or maybe something is really happening. When I was a young physician, I was at New York Hospital, but when I first graduated from Cornell and Payne Whitney, I went up to St. Luke's. And what I noticed at St. Luke's was that patients were different. The schizophrenia was more virulent. There was much more schizoaffective disorder. And that was clear to me that uptown Manhattan, there was much more use of stimulants and marijuana, much greater uses than there was in Midtown Manhattan, right? And it was a social class thing at that point. That social class difference is much less now. In the high schools in the metropolitan area, kids are drinking at an earlier age, they're smoking marijuana at an earlier age, and the drugs are more potent. I think this has had a real consequence. I can't pronounce Danish, but Professor Hochstraat, I believe, in Denmark, they just published a paper just last May, but there's a series of papers from really, high-class groups studying statistics. In Scandinavia, there are medical records on the whole population, so you can access very carefully the records of treatments of the Scandinavian countries. The rates of schizophrenia have been going up for the last 10, 15 years, quite remarkable. And when they look at the cases and try to tease it out, they think that cannabis use is driving a major increase in the incidence rates of schizophrenia. And they estimate, for example, in Denmark, where they've done this, that the percentage of cases presenting now would be approximately 15% less. Now, if you work in New York City, you think of the number of cases admitted to Bellevue of severe psychosis. And if you take into account what that would mean, a 15 to 20% decrease in the number of cases presenting to ERs for psychotic disorders, that's an enormous burden on the whole system, all right? But more than the burden on the teams working all night in the emergency rooms is those individual young people and their families, and I think the community as a whole. I think we have to think about what's happening and take it very seriously. Now, the classic schizophrenia in the old books were called dementia praecox. It's a dementing illness of the young, okay? It was so that they were focusing on a lack of overall functioning. There are multiple systems involved in the brain: cognitive systems, interpersonal systems, emotional systems. When you have a disease that interferes with how a person lives their life and interacts with others, you can see, I don't see how a particular medication is, you're going to look to a medication, even if it's being sold as an antipsychotic, is going to make a difference. So it takes a team of people from different perspectives to treat these patients. It takes more than just a team. It means the society has to change the way in which it interacts. Things don't work, you have to try new things, or maybe go back to old things. So medications may be necessary, but they're not sufficient, right? And a central part of this whole project has to be getting families, helping, not only getting them to support, but to help families, support families, and support communities so that they can help with the care of these people. I think there's also a question of equity, equity because of in communities, to help communities deliver the services which are necessary. I said that we have treatments, so we have 20-something antipsychotic drugs. We have a system that allows people to be in hospitals. We have community mental health, yet we have exceedingly high failure rates. Why? Well, maybe people don't comply with treatment. They don't comply with medications. That might be because of trust between the patients, providers, families. I think in our own, we're our own world here, our environment, sobriety is an issue, right? If we believe that marijuana and alcohol will worsen psychosis in a society where, marijuana is on every street, in every dormitory, in every college in the region, we have a problem, right? When you have a disease that interferes with the ability to sustain social contact, then how do you get these people to sustain contact with treatment teams? How do you get into place teams that have stability to work with people over extended periods of time? You can't get someone better in 3 weeks or 3 months. I mean, our experience has been, it takes 3 years to make major inroads with the illness. So you need compliance, you need trust, you need sobriety, you need the way to support the families and other social systems to deal with the whole question of, long-term overcoming of the treatment resistance. Now, let's talk a little bit about what the treatments are. All the traditional medications, Haldol, Stalazine, and then those are the first generations, and then second generation drugs, Zyprexa, Risperdal, etc. They're dopamine blockers. So one of the theories of schizophrenia is that it's an excess of the dopamine system, right? Again, you can knock out hallucinations, but 40–50% of people don't regain high functioning. There is a medication that is a little different, right? That's Clozapine, and I'm going to talk about that in detail. There are new things in the pharmacological pipeline. You're probably going to hear a lot about them. Medications which are cholinergic, so acetylcholinergic activating drugs. The understanding or the recognition that a cholinergic drug could treat psychosis goes way back into the early 1960s. A direct cholinergic agonist, called physostigmine, when you injected it into somebody, could actually reduce psychosis, and it was marketed as anti-delirium, so the anti-delirium drug. And so they spent 40 years trying to produce something you could take by mouth that might do the same thing. So those things are going to be coming out soon. But Clozapine is different than other drugs in that it has a much higher rate of helping with negative symptoms than most other drugs. But you can't get anywhere, again, just by medications. There's got to be individual and group therapy, cognitive reorganization. And again, you have to get people out into the world. And I think, so it's hard for people to expect it, to talk about it. People need a sense of community. They need a sense of hope. They need a sense of purpose. And that's spoken of in terms of spiritual values. AA is a powerful tool, as far as I'm concerned, in many of our patients. And I look at that as a spiritual intervention in some ways. Now, Clozapine is a medicine that's been around for a very, very long time, since the 1960s. And though it is the most powerful antipsychotic with the best clearance rates, it's the least used of all the medicines. That to me is fascinating. Patients with schizophrenia have high suicide rates, yet Clozapine reduces suicidality. It reduces aggression, irritability. It controls the classic symptoms of schizophrenia. It knocks out hallucinations and delusions. It improves negative symptoms, and I'll even show you some data on that. There's some evidence that it improves cognition. When it works, it's quite impressive. There are case reports of patients on Clozapine essentially being, quote, cured, which is amazing. I've seen it a couple of times. It's not, doesn't happen all the time. So not every patient on Clozapine responds, but at least half of them respond very, very well. The lower life expectancy of patients with schizophrenia, even when treated, is impacted with Clozapine. That is, comparing patients on Clozapine to patients treated with Zyprexa, Risperdal, and other drugs, is that patients on Clozapine live at least 5 years longer on average. Now, why isn't Clozapine used? Well, 1 in 100 patients on Clozapine develop agranulocytosis, which means they will die of an infection. But there's all kinds of rules. If you use Clozapine properly, that never happens. But it means to use Clozapine, you have to have blood tests every week. In the beginning for the first 6 months, and then every other week, and then once a month. If you follow the rules, you don't see agranulocytosis. Clozapine patients, they gain weight more, so you would think that they would have more physical problems. But actually, if you can work them so they do better, they can also develop other conditions like myocarditis, etc. But again, they seem to do better physically, and it might be that since there's all these rules about using it in blood tests, they have to see their doctors more often and are followed more closely, and therefore get more attention and do better. But the European data is quite clear that it's the best of all medications and all the interventions we have up to this time. I just stressed it's underutilized. I think the rough figure is that only 2% of the psychiatrists in the United States use clozapine, which is a problem in my mind. Okay. So what makes the clozapine most useful is trying to address the negative symptoms, right? It gets them better, and I'll show you some data on that. But it's not good enough. In other words, if you have a patient, you get them out of the hospital with a medication, if you get them functioning a little better, maybe they have a part-time job, that maybe that has to be your objective, but you might set your target higher, right? Can you get somebody back to school? Can you get them into the workforce? In my mind, can you get somebody having a relationship with other people, maybe even getting married or something like that, in the 20th century, it's the 21st century, I don't know. Is that still possible? So over the years, we've tried adding lots of different medicines to the clozapine, antidepressants, stimulants, the same medicines they use to treat Alzheimer's disease because of the cognitive. We tried all kinds of interventions. We fell into using a neurohormone called oxytocin. When a mother breastfeeds a baby, she produces oxytocin that produces letdown. And when a baby is born, the birthing mother produces huge quantities of oxytocin. It's part of the birth process. But oxytocin is also a neurohormone and a neurotransmitter. And it's involved in a lot of interesting processes. So just to be academic, that's the 9 amino acid sequence. There's a whole bunch of things it does. I mean, it helps you lose weight. It relaxes people. It improves bone density. It stops bleeding if you're bleeding in pregnancy. It relieves pain. It's an anti-inflammatory drug. It increases wound healing. At the very bottom, I say it increases regeneration in the hippocampus. The hippocampus is the part of the brain that's involved in memory and learning. And both oxytocin and clozapine actually affect those regenerative cells in a positive way. So there may be something really powerful going on as an interaction. That would be a whole lecture in and of itself. So what we do is, after we have patients on clozapine for an extended period of time, we add other medications, including oxytocin. And it's not just short term, we add it for months and follow the patients. The reason we chose the oxytocin was because we saw it help frontal lobe damage patients, brain damage patients. And one of the things that you can see with patients with schizophrenia is that it's also a disease of the frontal lobes. They're kind of negative and they don't motivate well, have trouble with focus. And that's why we tried it. And we saw some improvement with them. And so we began pushing its use, okay? We give it differently than other groups do for other reasons. We use sublingual. We have it made into a little wafers you could put under your tongue. We do that because so many of the young people we treat were substance abusers, and they were abusing, they were snorting medicines and drugs. And so we don't want to give them a medicine that they're snorting. It's also a cheaper way of having it made. But I'm not giving a lecture just on the oxytocin, all right? But on the clozapine mixed with it to treat, this is really about treatment resistance and impacting it. The clozapine, we think, helps repair the gross psychotic symptoms and it helps with regulation, mood regulation. Clozapine, in addition to being a useful drug for schizophrenia in Europe, is used for bipolar illness. So it's actually a mood stabilizer. The oxytocin seems to help with interpersonal relatedness and motivation. People seem to be more motivated on it. What they describe to me as being less anxious and more able to initiate action. And both of them seem to, since their oxytocin helps with the anxiety, and the clozapine seems to interfere with substance abuse, it helps people maintain sobriety. And if you think about what I've been saying about these virtuous cycles of interaction between people and individually and society, if you're less anxious, if you can be more social, if your cognition is improving, then you can improve in many different kinds of ways. So that's sobriety and social support and compliance all begin to improve when we do this. Now, this is very busy, but these give some of the literal cases. So if you look at that PAN score, the fourth bin, PANS on admission, those are psychosis rating numbers. The higher the number, the more psychotic the patient. So I run about 40 on that scale. All right. And we all do in the 30s. If you're running in the 50s and 60s, you're impaired. If you're running in the 80s and higher, you're pretty psychotic. Okay. And so what you can see, if you just look at individuals, you put them on clozapine, and you can knock off 20, 30 points. You put them into a situation where they can function a lot better off, and they can begin to go in the world. They're released from the hospital. They're doing better than other medications. But if you add oxytocin 3 months, 6 months later, you'll drop another 20 points. Those 20 points are the critical points that take you towards the range of normal functioning. Maybe not necessarily in it, but close. And that's where you get an acceleration of the virtuous cycles of interaction internally, interpersonally, and intersocietally. And these are all these, like, for example, each of these people went to college, and out of this group, some of them have finished graduate school. Now, finishing graduate school when you were said to be schizophrenic is a pretty remarkable thing. Having the full-time job, in my mind, is a pretty remarkable thing. They've stayed on these medications, all right? None of them have married yet, but several are involved in long-term loving relationships, which to me is one of the most powerful measures of change. The other thing that is pretty powerful is what happens with their families, because people with severe psychotic illnesses become estranged often from their families and friends and others. And what the families describe to us is the reconciliation coming back into the families, and a sense of increasing hope between them. This is, again, powerful. Now, we can't do double-blind studies because we treat everybody who comes to us. And we don't put everybody on oxytocin. We put the treatment failures. Remember I said 40, 50% of relative treatment failures, et cetera. So we don't put everybody on it. But so this is some of the worst patients responding better than patients who aren't so bad, which is pretty instructive in some ways. But I'm not going to read these to you, but maybe, I'm always touched by Reborn, Not Locked Up Alone. He completed college and went back to sports. Actually, that young man is gone back after college to do advanced training and has a job. One of these people here finished graduate school at NYU and has a full-time job. Several of them are, interestingly, got master's degrees in computer science. One of them is going to MIT next year in neuroscience. And he has symptoms, but he can function at a very high level on this mix. So what can I extract from this kinds of things? Well, the mixes of medications, which can be complex. I mean, it will not only be clozapine and oxytocin, there may be provigil, lamictal, et cetera. All right, but the object seems that they get more responsive, more social. They're able to go out. They can participate in AA. that to me is one of the earliest markers of getting better. They go to AA and they participate. They're involved in their own lives and those of others because they're more relaxed. They want to go back to school and work. They attempt to socialize, and they don't return to substance abuse. There's to maintain sobriety, and there's decreased impulsiveness, and then there's going off to work. There's barriers to treatment, especially where we live. We don't have sufficient resources, treating staff. There's bureaucratic interferences to getting things done. There's one of my favorite Greek words, anasagnosia, right? Denial of illness so that people don't accept treatment. We still have limited understandings of the neurosubstrates of what these illnesses are. That limits our therapeutic options overall. And that's after spending billions of dollars on study. These are resistant problems to solve, right? And then we live in societies with which there's a great deal of social conflict and availability to substance use, which makes this subgroup of people have a very, very difficult time in my belief. But I keep on saying this because I like the idea that we have vicious cycles that lead to failure, but we have to oppose them with virtuous cycles of interaction. And it's not about an individual, it's about a social system, right? And again, always the families. The families need support so that they can help, their ill family members. And there has to be interconnections of all these people helping each other to do better. And this is where we get into the hard part, right? I mean, sometimes people try to do good and it leads to problems. So our legal system makes it easy for people to opt out of help, opt out of the shelters, opt out of treatment, and that leads to worsening outcome and overall greater cost. We have bureaucracies that fragment cost. In Europe, it's less fragmented, right? Our social service agency can get the aid to start new programs, and it's difficult here to do that. I think the philosophy of the age, which is more secular, leads to social isolation, right? And the emphasis on freedom of choice when it comes to drugs leads to worsening symptoms, suicide, violence, and death. I think we have to admit it, that really has been happening. And we can see it in the increased numbers of overdose deaths in the country as a whole. The whole Vietnam War, there was, I believe, 60 to 70,000 American deaths. So that was over a 5 to 7 year period, depending on how you counted, up to 120,000 overdose deaths a year. This is not a good situation, and it has to be addressed in some way. And I think we have a responsibility to do that. So I tried to give us 15 minutes. Did I do okay, Amanda? Good. So I put my glasses on. No, I can listen.
Great. You did great. Thank you so much. And we have a lot of questions coming in. So I can start fielding some questions. All right, let's see. We have a couple coming in. One individual is asking about whether or not you can comment on research on gluten and psychosis.
Yeah, I can comment. I have no expertise. My comment is that if you get me going, I'll talk for hours, that it's not a single illness, right? But inflammation is a general problem in illnesses. Mm-hmm. And gluten is an inflammatory substance. And some people it will induce the immune system to produce excess antibodies, right? One of my canned lectures is on COVID and schizophrenia. COVID induces what kills you in COVID, if it does, is the immune system's hyperreactivity. Some of those antibodies cross into the brain and attack the hippocampus. The hippocampus, I think, is a central part in the frontal lobes of schizophrenia. So can gluten do that? Yes, right? There are autoimmune disorders which induce psychotic states. So sure, I think so. What to do about it, how to treat it, I don't know. Other than diet, but yeah. I mean, one of the boys on that list, well, actually, there's another 40 names. You know, he had a chronic infection, and as we treated his infections that had gone on for years, he began to improve. We were also giving him oxytocin, but I don't know what's the main issue, right? He reconciled with his family, he began talking to people. Again, it's no one thing to me, right? It's a complex.
Right. Another question's coming in about a correlation between schizoaffective disorder. Do you see any correlation between schizoaffective disorder and being diagnosed with ADHD in early childhood?
Yeah, as part of one of the other lectures, if we looked at, say, 100 young people admitted with schizophrenic spectrum disorders, okay? It's not just what I've seen, it's in the literature, right? You see that at some point early on, the ones who 10 years later will have that diagnosis early on will be called ADD, and will often have been treated with stimulants. All right. Now, did the stimulants induce schizophrenia? No, I think not. I think it's a developmental disorder of the brain and the way in which symptoms present over time, distractibility, cognitive issues, right? Frontal lobe issues, to the extent that what we call schizophrenia involves disruption of the temporal and frontal lobes in the deep circuits. You're going to see presentation of subsymptoms of the illnesses at different rates, right? And it'll look like ADD. And that's why often really good psych testing, you know, which isn't just rating scales, can be very helpful to try to tease it out. Because you don't, in my mind, you don't want to make the mistake of treating a slowly developing psychotic illness with stimulants, because there is evidence that that will worsen it, right? Because you can induce psychotic states with excess stimulant use, right?
Right.
And as well as we now, there's evidence going back that cannabis can do the same kind of thing in vulnerable people. So you don't want to mistreat and play into the negative part of the process.
We have a therapist who's talking a bit about how they have had clients who have been hospitalized or incarcerated and medicated over objection.
Yep.
Any words of advice regarding the roller coaster ride of having them receiving the meds, being discharged, released, and then refusing the meds, and then, you know, so on and so forth, the cycle continues?
Yeah, I think that's one of my subtexts. That's a vicious cycle. And what you're reinforcing a terrible pattern, right? And this is an ethical question, right? Which is an aesthetic question. How does the society organize itself? What is considered true and beautiful, right? And so how do you parcel that out? I mean, how do you have a system in which there's enough of an attempt to engage with people so that they help convince them of the righteousness of it? You know, right now, I have two people working for us here at the hospital who are our patients and are on Clozapine. Now, so imagine if, you know, what that means. I have a patient who is now a distinguished, you know, doctor in mental health, and he's on Clozapine and functioning at high levels. If people, you know, I think that the way to help is if we can take people through the system, that they function in such a way as it becomes an example of what can be done, then trust will appear. But right now, you know, one flew over the cuckoo's nest is embedded in people's minds, right? That we are up to no good. We're agents. We're agents of state oppression, right? We're not people trying to help. And I think that's a problem.
Yeah.
I don't know if that's answering your question. I mean, you know, it's a hard thing. You know?
I mean, it's clearly a systemic issue that I don't think that anybody necessarily has the answer to. It's complicated.
Yeah. Right. Real life is complicated. the answers may be simple, which is, if people care for each other enough. I mean, there's always going to be loss. There's always part of human history. But I think right now there's too much wastage, right? The potential.
Yes.
Much
Yes.
yeah.
We have an individual who's asking, what is the earliest age that you can clearly diagnose schizophrenia?
I am old enough to have been taught that I couldn't diagnose depression in anybody younger than 13 because depression didn't exist in children. I mean, and I'm old enough to have been in a graduate seminar where I was taught that schizophrenia was caused by mothers, right? Schizophrenic mothers. So there are very early cases. So if it's a developmental brain disease, disruptions in behavior of an extreme sort can be seen often at an early age. So is that dementia praecox? Is that what Professor Kreplin saw in Munich in 1899? I don't think so. All right, it's I mean these are names we give to things. So there are terrible neurological illnesses, forms of epilepsy, forms of degeneration, which present with terrible disruptions of behavior. Okay, and so they may appear early. A form frusta, which is a technical word for partial expression of that, may look like schizophrenia. But I don't own the word schizophrenia, right? I mean, at the meetings in Florence the year before, there was a discussion of whether or not we should get rid of the name, right? Whether we should start using 8 or 9 different names and try to parcel it out. I mean, epilepsy is a general name, but there's 70 different forms of epilepsy. Maybe we have to, because I think that it is, that's probably something like that's going to happen. There has to be individualized treatments because the pathophysiologies are different, but also the human beings, their lives, what they've been through are different, right? A real treatment plan can't be give them a shot of, Haldol, decanoate, and release them to see their therapist once a week. I don't see that as a treatment plan.
What would you say then would be, what's the youngest patient that you've treated with Clozaril?
13-year-olds, 14-year-olds. Yeah, which in Europe they'll do. They'll do some, it's not that they're braver than we are. Their system is set up to treat and follow closely, right? I mean, we're fragmented, right? A really severe case in Great Britain will go to a senior consultant at the Maudsley, and they'll make a decision and they'll put into place a treatment plan eventually. It may take them a long time, but they will. If you had a grand idea for a treatment program on the west side of Manhattan that you thought you could implement, and you were in Sweden or Holland, you would actually get funded.
Right.
They would try to make it work.
Mm-hmm.
You wouldn't be raising money on the downtown to try to make your salaries. They'd be helping you do it. They'd be helping us do what we're doing.
Right.
Yeah. So when I speak with them, poor American boy, you don't have your poor country don't have any resources.
Well, there's so much just great research that you're collecting out of it as well.
But see, research we collect doesn't count as research because it's not double-blind, placebo-controlled. It's not the gold standard. But we have to make a decision about treatment. If we're treating people come to us for help, they're not coming us to have research done on them.
Correct.
And when we make a research proposal, there's always a reason why it can't go through. It's very expensive to do. It's millions of dollars to do a double-blind study.
Yeah. Again, more systemic
Yeah.
issues.
Right.
This is actually a good question as well. Can you speak to the nurture piece of nature versus nurture when it comes to schizophrenia?
It's real, right? I mean, the intensity of illness is determined by how you're raised, how you deal with it. And so the nurture is how much mommy loved you. I think that's very important, but it's not sufficient, you know. It's necessary, but it's not sufficient to try to use an old philosophical term, right? I mean, life has been watching with the calling the midwives. Is that she's been watching it for weeks now, and it may be. I was raised Catholic in the cities. I was educated by nuns and priests, you know, and in retrospect, that thing about the midwives, that some of them are nuns, and they were. I'm watching this program from Great Britain, and the people in it are so familiar to me because they remind me of the priests and nuns I was raised around, and their commitment to others, the way they express their love of others. So the nurture of the family and of the community to me is an incredibly important thing. But also the treatment team. I mean, I have the most amazing treatment team here, right? I think of them, since you got me going, as a bunch of saints.
Yeah.
You know, now how they got to be there, I think, is because of their own suffering in their own families and individually. But they're saints, right? And that's part of what I say is a virtuous cycle of bringing these kids back, right? I mean, to see a totally withdrawn, isolated schizophrenic boy hug one of the nurses' aides or nurses, right. It makes you cry, but it's that kid has more of a life, you know. And for years he didn't, and I've seen that so many times. I mean, I'm privileged to work with these people. I really am.
Yeah. I'm gonna get one last question in. Can you comment on hypersexuality and schizoaffective disorder? Are there specific medications or treatment options that reduce hypersexual symptoms?
Sure. It's gender specific, but if you think of schizoaffective as being a combination of bipolar illness and schizophrenia, right? Because, you know, the bipolar subtype, impulsive activity of all kinds, right? And again, if you live in a society where there's drug, sex, and rock and roll, you know, the high interest of the population, that's what you're going to get. And people are going to search for some connection. I mean, so any medication that interferes with impulsivity might be useful, right? But it always, things like that depends on the individual case. Now, hypersexuality is seen in certain forms of epilepsy. We've talked about epilepsy, right? All kinds of strange things exist, right? And it's the individual story that will tell, right? Was there abuse? You know, is there something else? Is there a tumor of the pituitary producing high levels of some hormone? I mean, that really happens. You know, if you see a lot of cases, you see all kinds of things, right? So in a hospital, if you live long enough, you may even see, you know, Wilson's disease. I've been waiting for 50 years to see a case of Wilson's. Is it House? House has seen 7 Wilson's disease in six seasons, and I've never seen one. But these things happen. But the epilepsies, to me, are interesting because, especially if you abuse drugs that follow the seizure threshold.
Right. Yeah.
You know, and which is alcohol does, and amphetamines do, and other medicines do. So if you want to see interesting cases, practice in the New York metropolitan area or any other big city in this country, and you'll have an incredible education in what can go wrong.
Well, thank you. Thank you so much. There's so many more questions, and as always happens with good presentations, just simply not enough time, but I promise that we will do more of these and give everybody an opportunity to continue to learn from you, Dr. Marotta, because you're such a wealth of information on this topic. everybody will be receiving, following this presentation, an email to obtain your CE certificate for the presentation. As I said at the beginning, if anybody wants to listen to the presentation again, you can access it through our YouTube channel, which we will be sending out information on as well. And please keep your eyes open for emails for upcoming CE and CE collaborations. Thank you all for attending. Thank you all for your participation and all of your questions. And most importantly, thank you, Dr. Marotta, for taking
Can you send us a link too? Because, you know, Catherine and I need CME to be allowed to continue to practice.
Yeah, you get I think you actually get an extra half of a credit for doing the presentation. So I promise you'll get.
We'll keep me working another week. Okay.
Yeah. All right. Thank you, everyone. Have a wonderful afternoon and evening. Take care. Bye.